Assalamu alaikum wa rahmatullahi wa barakatuh. This is an introductory lecture to introduce the MRCPcH Part 1 course. I am Dr. Shahinda Ahmed Adel. I am the course instructor. We'll be pleased to lead you through this introductory lecture to know about MRCPcH certification and MRCPcH Part 1 course. The MRCPcH stands for Member of the Royal College of Pediatrics and Child Health. So that's the title you get when you complete all 3 exams for this certification. The membership of the Royal College of Pediatrics and Child Health is achieved by passing 3 theory exams and 1 clinical exam. That's the way the Royal College put to pass this certificate and be a member of the Royal College. So we have, as we said, 3 theory exams: Foundation of Practice exam, Theory and Science exam, and Applied Knowledge in Practice exam. Each one of them is commonly referred to as FOP, TES, or AKP exams. In the past, we used to call FOP and TES exam Part 1 exam, so that's meant by Part 1. Part 2 is the Applied Knowledge in Practice theory exam. These are computer-based exams. We will be talking about it in a minute. And then after passing the 3 theory exams, you are eligible to register for the clinical exam, which is actual clinical setting exam. Okay, so this is the way to get the MRCPcH certification. How to take the theory exams? The first important step, which you should not delay if you decided to take the exam, is to register. Register means creating an account, identifying yourself to the Royal College as a probable candidate for the exams. So you can register anytime on the website, at any time throughout the year. There is no time for registration. Registration is simply recording your name, your job title, your certification from your country, and it ends by uploading a certificate of your medicine degree in English, so that the RCPcH, the Royal College, will identify you as a candidate and will give you an RCPcH number. This is a very important step because this number will be the number you deal with all through your exams and mails and communication with the Royal College. After that, the Royal College will confirm your registration. It may take a week or several weeks, so you should start registration way before your planned exam date, and you should choose a password. By the number and the password, you have created an account on the RCPcH website. Then you have to study when is the timings for your exams. Theory exams are computer-based exams that are held 3 times each year. Part 1 exams, the FOP and TES parts, takes place in February, June, and October of each year. Part 2, the AKP, takes place in January, May, and September of each year. But in this introductory lecture, we are concentrating on Part 1 exam. So that's our main focus. Okay. To apply, for example, for the exam in February, usually the application date is about 3 months earlier. And the application period is different from one country to another, slightly different from one country to another. So you should always go to the website, search for application dates, and search when is your application period in your country. You should apply in the very first day, in the very first hours of the application date, because nowadays there is a huge competition on exam seats. So the exam seats are rather limited, and they usually run out of exam seats a few hours after opening of the application period. So again, if you are planning to go to the exam in February, for example, you should expect the application time to be about 3 months earlier. That's about in November, sometimes in November. And you should go to the website and just search in your country when is the application date, and be very, very meticulous about catching this date and applying early. Let's talk about Foundation of Practice exam. It assesses the candidate's knowledge, medicine knowledge, understanding, and clinical decision-making abilities. And it's a part of the MRCPcH certification, and also another certification, which is the Diploma of Child Health certification exam. That's another certification that allows you to begin practicing pediatrics in the UK, but a step earlier, يعني a step lower than the MRCPcH certification. The MRCPcH certification is the complete certification of pediatrics training. It allows you to get into pediatrics training at what we call the ST4 stage. It equalizes you with the medicine graduate in the UK, which is eligible for practicing pediatrics right away. That's an ST4 level of training. The exam lasts about 2 hours and 30 minutes, and it was formerly called MRCPcH Part 1A. That's the old name. The type of questions in the exam are typically 2 types. The single best answer, which are 70 questions. You have to choose one best answer of 5, and the extended matching questions, which are 10 questions. In the extended matching questions, you are faced with 10 choices at the beginning of the question, usually in the same area. For example, 10 diseases of the respiratory tract. And then you are faced with 3 scenarios, 3 different clinical scenarios. You are asked to choose a clinical one diagnosis for each clinical scenario out of these 10 probable diagnoses offered to you in the beginning of the question. We will be practicing some of these questions, or the types of this question, throughout the course. The theory and science is a little bit different than FOP exam. It is also a part of Part 1 exam. It was formerly called Part 1B exam, and it again tests the basic scientific, physiological, and pharmacological principles of clinical practice. So it's more concerned with the basics, the pharmacological basis, the physiological basis, sometimes the anatomical and embryological basis of medicine practice. It can ask about a certain clinical decision, but usually the clinical decision is related to some basic concept. That's the difference. That's why regarding TES exam, you have to study the basics again. Of course, the part of the basics related to the pediatric curriculum. It also lasts for 2 hours and 30 minutes. As a candidate wishing to pass Part 1 exam as a whole, you can choose to apply to FOP and TES exam on the same day. FOP is always in the morning, and the TES is in the afternoon. There is about an hour recess between them. Or you can choose to apply to only one of them at a time. Be a candidate for FOP or TES exam alone. The 3 theory exams that we mentioned in the beginning the FOP, TES, and the AKP exam can be passed in any order. There is no particular order to go through these 3 exams. So for example, you can choose to get into FOP exam, TES, and then AKP. Some candidates choose the opposite, choose to go through AKP, Applied Knowledge and Practice, because it's more related to clinical practice first, and then pass the FOP and TES. There is no particular order that you should go, that you should follow passing these 3 theory exams. You can get through them in any order you like. The only condition that you have to pass the 3 exams before registration for clinical exam. Clinical exam is the furthest step, the last step. Okay, so some candidates prefer to go through the 2 papers together, FOP and TES, in the same day, and some prefer to take it 1 step at a time, FOP, then TES. The types of question in the TES exam is the same as the FOP. So again, we have to select the best answer out of 5 and pass through the extended matching questions. Now, the very important question we are asked all the time from candidates: what source of studying should I study from to pass these theory exams? The source of studying can be summarized in this slide. You have textbooks, you have well-known textbooks for passing the MRCPcH exams, you have our course material, you have question books. There are many question books in the market. We will line out now what are the important question books to have, and you have also the past test or on examination question banks, which are very important for getting into the spirit of the exam, getting used to solve such questions in limited time, getting the spirit of how he would ask you about a certain information. It's very important to practice these questions, not because they come in the exam as they are, but because they give you the skill to read a long question and solve it readily with confidence. Textbooks. Again, many textbooks can be studied from. We recommend these textbooks to be on hand. You don't have to study each textbook from cover to cover. But these textbooks are recommended by many candidates before us. We have studied from them, and many candidates that are still going into the exam find it very useful. The Science of Pediatrics textbook, formerly called the Master Course, Illustrated Textbook of Pediatrics, a very nice textbook, and Training in Pediatrics. Some candidates also found Essential Revision Notes in Pediatrics, which is a very concise, pointed out source, very useful. And there is a common book between part 1 and part 2, the Survival Guide. Okay, it summarizes the experience of one candidate of what he finds important, what are the important points in pediatric clinical practice that he finds important to line out for future candidates. So these 5 textbooks actually are the most important ones. Should I have them all? They are all present in PDF format everywhere. So I advise that you should download them and have a look on each one of them. We are not the same regarding how we study. So one candidate may prefer a concise, pointed out source like Essential Revision Notes. Other candidate may prefer an illustrated form filled with many pictures, many illustrations. The SOP, or the Science of Pediatrics, is the most recently updated source of studying issued by the RCPcH, recommended by the RCPcH, and it contains actually many of the basic information we teach in our course. So just have a look on each of them and keep in hand 1 or 2 textbooks just to refer to when you find yourself having a subject that you are not very sure of or you need to read more about. The question books are many in the market, but the two most important question books, again recommended by the RCPcH and issued by them, are the clinical cases for foundation of practice, clinical cases for theory and science. Each of them contain about 40 to 50 cases, and then the answer of each case is a very comprehensive explanation of the subject. So actually it's not a question book, it's a source of studying. Every information mentioned in these two books are very important to pass the exam. How will our course help you? So if I have the textbooks, I have the question books, I can go online for online past test and all examination. Why should I take the course? We try to summarize these 5 textbooks for you. Each textbook is distinguishable in a certain aspect. So we as candidates have gone through all of these textbooks at different times. We save your time by summarizing the textbooks, giving you the summary of the 5 textbooks together. We try to incorporate the information mentioned in previous exam questions through our course material. So you will not have to go through the previous exam question all at one time. When there is a new information mentioned, for example, about cystic fibrosis, we incorporate this piece of information while we talk about cystic fibrosis and so on. We go through cases in question books, again, extract important new information and put them in their probable site, in their suitable site, inside course material. All through our course, many important topics will need to go through the UK guidelines to know what to do according to the UK guidelines. This is a very important part, especially of the FOP exam, to know what to do according to the UK guidelines. So there is no single source for guidelines to study from. We gather up guidelines from websites, from books, from PDFs, and try to summarize the important point for you in the course. At the last lecture of the course, we go through the sample paper questions. Sample papers are 2 papers put on the RCPcH website. The answers are provided, and they are very important because nearly each exam, 1 or 2 questions come from these sample papers. So we go through the sample paper questions and explain and discuss them with each other. Lastly, we answer inquiries about unclear points in our WhatsApp group. So even after listening to the lecture, reading the material, solving questions, if you find anything unclear questions, you don't know why the answer is written that way, you feel that there is something missing or you don't understand anything, you can post your question to the WhatsApp group and we will discuss it and answer it together. So here we would like to give you a short demonstration of how would the online lecture look like. Okay, so this is just a little demo. Okay, in this little demo we are going to explain how we talk about hypoglycemia, for example, in pediatrics. So first of all, you have to know what is the level of hypoglycemia. Hypoglycemia is defined as having a blood sugar of less than 2.6 millimole per liter in newborn, less than 3.5 millimole per liter in children, and less than 4 millimole per liter in any child taking a glucose lowering agent. Notice the unit used here, the millimole per liter. This is the UK unit. So we should familiarize ourselves with the units used in the UK. Symptoms of hypoglycemia can be very, very unclear in pediatrics because they resemble the normal child behavior sometimes. The child may be shaking, sweating, anxious, dizzy, feeling hungry, unusually hungry. He may have a fast heartbeat. He may have an impaired vision. He may be weak or fatigued or just complaining of a headache or, believe it or not, just being irritable. So when a child is irritable, you have to suspect that he is hypoglycemic at the moment. As you can notice, all the symptoms can be misjudged as a normal fussy child behavior. So when we have a child who is specifically at risk, we know that he is going through hypoglycemia sometimes, or on any glucose lowering agents like insulin, for example, we instruct the mother to be very, very alert to these symptoms. And we even instruct her that when she suspects being hypoglycemic for her child, noticing these symptoms, to correct hypoglycemia even if she cannot measure his blood sugar right away. For example, if they are out, they don't have the blood sugar device right now, I would say give him something to eat and then measure later, because hypoglycemia is very dangerous. So if you suspect hypoglycemia, correct it first and then measure later. Now, what's the source of hypoglycemia? How does the child become hypoglycemic? To understand this point, we have to go through very rapidly through how our body reacts when hypoglycemic. So, for example, in the fasting state, when we stop eating for a short time, the first source that we go to is the liver glycogen stores. That's the first store to be broken up to provide glucose. Okay, so actually it provides glucose that goes into the bloodstream, which is a very important fuel to the brain. That's why we keep alert while we fast. But the glycogen, the liver glycogen, lasts for the first hours of fasting, only a few hours, 3 to 4 hours, maximum 6 hours. Okay, now glucose given up from glycogen lasts for a few hours in the bloodstream, provides the most important organ, which is the brain, with a continuous supply of glucose until we run out of liver glycogen. Then we go to the second source of energy, which is the fat, the triglyceride stores. The first step is to break triglycerides into free fatty acid and glycerol. Glycerol goes to the liver to go through gluconeogenesis, the formation of glucose again, while free fatty acids go to the liver to be burned out by free fatty acid beta oxidation. The burning of the fatty acids provide us with another fuel, which is very important for the brain again, which is ketone bodies. Ketone bodies are not purely harmful bodies. They are the second source of fuel that the brain understands that he can utilize. So our brain can utilize glucose if it's present, or ketone bodies if no glucose is present. Muscle, on the other hand, has its own mechanism of facing hypoglycemia. It stores its own glycogen that can be broken down to provide anaerobic oxidation of glucose inside the muscle, producing pyruvate or lactate. So glycogen is broken directly to form pyruvate or lactate. It can also break proteins to amino acids, which again goes to the liver to perform gluconeogenesis. It cannot utilize fat. Okay, so as a body, as a whole, the most important organ functioning in our body, which is the brain, now understands two types of fuel: either glucose from broken down glycogen, or ketone bodies form broken down fatty acids. So why does the child become hypoglycemic? When the child becomes hypoglycemic, the insulin release is decreased accordingly, and the anti-insulin hormone is increased. The anti-insulin hormones are the glucagon, the glucagon, the adrenaline and noradrenaline, and the cortisol. These hormones stimulate the mechanisms by which we make up for the missed glucose, stimulating glycogenolysis in the liver, producing gluconeogenesis in the liver, and beta oxidation of fatty acids, the mechanism we just talked about. So if we find a child to be hypoglycemic, that means that one of these mechanisms is failing. The first step to do when we find a child with repeated attacks of hypoglycemia is to assess, does he have high levels of urine and blood ketones or not? By testing the presence of ketones, we test the fatty acid oxidation mechanism. Is he allowed to have fatty acid oxidation? So if we find that high ketones, we call it ketotic hypoglycemia. This is the first type of hypoglycemia faced in children. In this type of hypoglycemia, you will find the insulin to be low, because insulin forbids fatty acid oxidation. Whenever we have high insulin, there is no oxidation of fatty acids. Insulin, as we know, is an anabolic hormone. It builds up fat in the tissue, and whenever the insulin is high, there is no breakdown of fat. So when we find the products of fat breakdown, the ketones, insulin must be not high. The conditions in which we find this type of hypoglycemia is, for example, when we have an inborn errors of metabolism like glycogen storage disease, a missing enzyme that inhibits or makes the glycogen breakdown difficult. So we have stored glycogen, but we cannot utilize it. So we go directly to the fat burning. Or when we have low stores of glycogen, like in prematures or in hepatic failures. Okay. Another example of this ketotic hypoglycemia is a normal human being who just have a very high basal metabolic rate. So he consumes up his glycogen very rapidly. That's called idiopathic ketotic hypoglycemia. Or if we have a lack of anti-insulin hormone, there will be no stimulus for glycogenolysis, like in Addison disease, the lack of cortisol. These are examples of ketotic hypoglycemia. So in ketotic hypoglycemia, there is a problem with glycogen breakdown. That's why we jump to fatty acid oxidation directly after a very short period of fasting, and that's why we find ketones in the bloodstream. Ketotic hypoglycemia. If we did not find any ketones in the bloodstream, although the child is hypoglycemic, it means that we have finished the glycogen stores and now we cannot burn fat. We cannot go to the second step to burn fat. So the two options of this disorder is having high insulin. High insulin consumes glucose in the blood to build up fat, but does not allow the fat to be broken down again when needed. Or we have a problem with fatty acid oxidation. We ran out of glycogen stores and now we have a problem in the enzymes performing the fatty acid oxidation. To differentiate between these two, we measure the level of insulin. So in the case of high insulin, we will find hyperinsulinemia and normal free fatty acids. But in the case of fatty acid oxidation defect, you will have high free fatty acids. There is an accumulation of free fatty acid in the circulation that cannot be burned down. due to lack of certain enzyme in the beta oxidation cycle in the liver. Okay, like carnitine transporter defect, for example. Okay, so to differentiate, we measure the level of insulin and free fatty acid. High insulin and low free fatty acids diagnose hyperinsulinemia. Normal insulin and high free fatty acids diagnose beta oxidation defects or fatty acid oxidation defects. Now, the last point we talk about here is how do we know the source of this high insulin? Whether the child is taking extra exogenous insulin or producing extra endogenous insulin. We test for something called the C-peptide. When the source of insulin is endogenous, it's produced in the form of proinsulin. This is inactive insulin. The active insulin is linked to the green part of the chain, which is the C-peptide. After that, the insulin is freed from the C-peptide to work as active insulin. So when the source of insulin is endogenous, we find increased C-peptide, increased product of activation of endogenous insulin. While exogenous insulin comes already active without its C-peptide part. So to know the source of insulin, we just measure the C-peptide portion. If the C-peptide is high, it's an endogenous source, like an insulinoma of the pancreas. If there is no C-peptide in the circulation, the source of insulin is exogenous insulin. This child is injected with insulin. Lastly, how to manage hypoglycemia. The patient is alert, can swallow, can protect his airway, he is not comatose. The best choice is to give oral liquids containing 10 to 20 grams of carbohydrates. In the UK, in the emergency room, they have like small gel capsules called glycogel. They have, each capsule contains about 9.2 grams of glucose. So they just give it to the child in the ER inside his mouth and he instantly improves. This can be repeated again in 10 to 15 minutes if the child needs so. If the patient is unconscious or symptomatizing, like fitting patients, having fits or having convulsions from hypoglycemia, I cannot give him any oral medication. So the first step is to correct his blood glucose by infusing or injecting 2 to 5 milliliter per kg of 10% dextrose intravenous. Second step is to give him an anti-insulin hormone like IM, intramuscular glucagon. The dose is 1 milligram if the patient is more than 80 years or more than 25 kilograms, or half the dose, 500 micrograms if less than 80 years or less than 25 kilograms. That's the emergency measures. If the child is discovered to have a state of hyperinsulinemia, he will get into repeated attacks of hypoglycemia all the time. For example, a patient with insulinoma of the pancreas. If I treated him emergently now, he will come tomorrow with another attack of hypoglycemia. So this child has to be put on certain measures to decrease the frequency and the severity of the attacks of hypoglycemia. That's by giving him glycemic agents like diazoxide or octreotide or nifedipine. These either work as anti-insulin hormone or stimulate the release of anti-insulin hormones like cortisol, for example, or growth hormone. If he is diagnosed with an insulinoma, sometimes pancreatic resection can be the choice for his treatment of the repeated attacks of hypoglycemia, resecting or excision of the insulinoma identified. In cases of idiopathic ketotic hypoglycemia, we talked about it here, the normal child with just a high basal metabolic rate that consumes up his glycogen stores very rapidly, maybe through the night, become hypoglycemic in the morning, especially if he skips dinner, for example. For this child, we just avoid extended fasts. We instruct the parents to give him small, frequent meals. He has to have dinner, and he has to have early breakfast. Do not wait for him to have breakfast, giving a bedtime snack and avoiding late breakfast. So this is how to manage hypoglycemia in different situations. I hope I have given you a nice demo about how we are going to go through our curriculum in the course. This is Dr. Shahinda Ahmed Ayadel wishing you good luck in your path, and always success is on the way. Thank you.